Okay, anybody have any issues or things they want to, okay, that's Christina, yeah?
Yes. I have a question. I wanted to know what the pattern might look like when both discs are displayed.
Yeah, well, it might look like that. There's a lot of complexity going on with Janice. It's interesting, right? Because there's often, sorry, I'm really not in focus, am I? I don't know what to do about that. That's my hand. Hello. Oh well, I guess I'm just fuzzy. So there's often an underlying pattern of hypermobility like throughout the whole body. And but then you're like, well, dude, like if you're hypermobile everywhere and you're hypermobile in your jaw, how come you have a disc problem just on one side? And it is very common to have like a uni, but it's also common to have both. So when you have both, how to say this? So if you've got the general hypermobility and then you have a specific trauma. I had this fabulous guy. He was a football player, and he was sitting in his car, and he got T-boned by a tow truck. And all that time, you know, he's on the field, and people are jumping on him, no problem. This tow truck hit him on the side, and it actually it caused this sprain of his left TMJ, and it was just this unilateral thing. So you can have like that kind of, I also had a woman, she's walking by a bar, this guy came out and he punched her in the jaw for some reason. So you can have these unilateral things and a history of trauma. You can also have general hypermobility, and it's one joint for some reason that is the one that's unstable, like more unstable. So yeah, so when you've got anterior disc displacement on both sides, you get this whole hypermobility thing. And in terms of the jaw, I don't know why I'm losing my focus there. We had great focus. Okay. In terms of the jaw here, when people open, you get rotation, and then you've got, sorry, I'm not looking at what I'm doing, I'm looking at the screen. So and then you've got the translation, this anterior movement. So the idea when you've got this, if you've got anterior disc displacement on both sides, that's great. You drop the tone, you know, in all the elevator muscles, and then you retrain people so that they're rotating and not doing so much translation, which I can't see because I'm on the other side of the camera here. But you don't want them translating so much. So that's where the stabilization exercises come in. Yeah?
Why do we have to rotate?
Well,
why does the jaw rotate and then translate?
Yeah, for sure. Okay, you got my screen. I'm gonna.
That's a question I had as well.
Great. There's a little PowerPoint on this in your notes here, but yeah. So there's two. Oh, what are you seeing right now? Are you seeing the? Yeah, you're seeing the PowerPoint, right? Yeah. Okay. So what you're seeing in the PowerPoint here. Oh yeah, and I've got my mouse too. So this is the mandible here, right? And here's your sweet articular disc. So there's a functional joint between the mandible and the disc. And in that joint, how do I say it? The only thing that can happen that's functional is that the mandible rotates upon the undersurface of the disc. It cannot, or it not to be able, it should not be able to go forward relative to the disc, because the disc is anchored here. This is collagenous tissue. This is the retrodiscal collagenous fibers. So the disc, the lower part of the disc is anchored to the neck of the mandible there. So if you try to move the condyle anteriorly, all that does, it snuggles it up tighter up against the disc here. Whereas you can rotate, you can bring this part of the mandible down, no problem. It's going to give you slack here, Bob's your uncle. So that's a way of opening. And so that's what happens when you get that jaw-dropping experience. Like, oh, your jaw just drops. That's rotation. That's a pure lower joint movement. Okay? But you can see, it only gets me that far. And like chewing and stuff is not possible. When I want to chew, especially when you got chewy stuff, you need to grind it. Then you need to move from side to side. Rotation's not going to carry it for you. So that's where the upper joint comes in, which I'm trying to show you now. Yeah. Okay, so in the upper joint, as the French say, n'est-ce pas? Oops, where is it there? Yeah, here's the upper joint. Now, we know that the, lost my mouse. It's coming back, I'm sure. There we go. Here's our condyle. It's attached to the articular disc, and you do that rotational thing, but the disc cannot go forward relative to the condyle in normal conditions. So the condyle disc complex has a relationship with the temporal bone here. So you can see that the disc is concave to receive the convex condyle. This is the temporal bone here. This is all aligned with articular cartilage here. You had an INSI, you get the fullness of the disc there. And as you go up on the articular tubercle here, you have this rounded eminence, and then you got concavity on your disc here. So that's why they say the disc is biconcave. It's concave on the top and concave on the bottom. So the condyle disc complex can translate as a whole forward, and it climbs, I would say climbing up the articular tubercle. It's really down, like when you're sitting or standing, but there is this kind of experience where you're running into the articular tubercle, and as you go forward, it's carrying you downward. So that's the thing that allows you, when you, let's say on the left side, if you're doing this on the left side and you're pivoting on the right, then you're going to be gnashing your teeth. So when you need to shred, the flesh of the mastodon that you killed with, your fellow men and women and their spears, you need to have this shredding thing going on. So translation, is going to carry the day for that. And just to review a little bit about the translation for fun, the reason this whole thing can go forward, the condyle disc complex, is you're like, oh, well, like we're connected with collagenous fibers, the condyle. Well, how come this stuff can go forward, like the disc can go forward? It's because this business here is a different type of fiber. It's elastin. So it's these yellow fibers, and they're more like little bungee cords, and they stretch. So that's what allows the whole thing to go forward. Is that like clear as mud, or how are you guys doing? It's tough, man, to wrap your head around it.
I have one more question.
Yeah.
If somebody was lost,
Yeah.
well, I guess I have two questions. How do you discern if it's the lower rotational part of the joint or the upper part of the joint, if they can't translate?
Well, let me just pause for a second. I just want to make sure I'm not going to say something that isn't true, to the best of my knowledge. Okay. My understanding, like from reading the literature and working with other professionals and from treating people, is that the lower joint is seldom a problem. like this condyle disc thing, is seldom a problem in and of itself. Sorry, was that? Okay, let me do the explanation, and someone wants to say something. When you're locked, you're either locked closed, so I can't open my jaw, or oh, I can't close my jaw. So you're locked open or closed. And if you're locked closed, then I believe that 999 times out of 1,000, what's happened is the entire disc is in front of the condyle. So on one side, you know, you're rotating like this, and the whole thing's moving forward, no problem. But on the other side, you're stuck behind the disc. And so you can rotate like this, that's not too bad. But when you try to translate, then you run into the disc. And the disc, this disc stuff, is still connected through elastic retrodiscal tissue. So it's like you're running into it. As you run into it, it bunches up until you get past it. If you don't get past it and you're stuck there, then you're stuck closed. Then you're condyle disc. Then you're stuck closed. If the whole thing, the condyle disc complex, has gone forward down the eminence, and then it goes on the other side of the temporal bone, then you're stuck open. Yeah, so here's the image of the reciprocal clicking. You're behind the disc, and when you click on, like back onto the disc, it clicks. And then here's the locking thing. When you're actually stuck and you cannot, you bunch up the disc and you can't get past it. I've got a fabulous kind of visual on that often helps people. I'll be right back. I'm going to get a tool. Say this is my condyle, and this is the articular disc that I'm hanging out on. Okay, something like that. So that's great. I can rotate. The whole thing can come forward and down. That's fabulous. If I get behind the disc, then I have to get back onto it. This is the click, and I'm onto it. So if it's just a little problem, I easily flick on. If it's a big problem, then I'm trying to get on. Meanwhile, on the other side of my jaw, everything's moving fabulously. So then as I'm trying to climb on here, the jaw's pivoting toward this side. And then if I finally manage to get on, then I'm going to have a click. And that's your mechanism between the early and the late clicks. So in this image here, the person's stuck behind the disc on the right-hand side. The left is rotating and translating. Off you're going to the right-hand side because you're just pivoting on the right. And then when they click on, then Bob's your uncle, they're more straight. If it takes longer, like when I really bunched up that book, you're going to be pulling a long time before you correct. And this late click is prognostic. Whatever symptoms the person has, it's going to be harder to settle them down, and it's going to be harder to maintain, a pain-free and comfortable situation. How's that going, Christina?
Yeah, that's helpful. Thank
Yeah.
you. I'm also interested in what happens when a joint fibrosis. You mentioned in the study manual something like a frozen shoulder,
Yeah.
frozen jaw. What's going to happen there, and how do you resolve that?
Yeah. So all those UFC, guys and gals. I was like, oh, I'm gonna take on George St. Pierre. So if you get, if you get repeated trauma to the joint, then you get these repeated episodes of inflammation, and you may have osteophytes and all sorts of other stuff going on there too. Then you get fibrosis like the frozen shoulder. But a frozen jaw, in my experience, doesn't unthaw. Frozen shoulders tend to unthaw. I mean, they say that they unthaw in like 18 months, but they're still, usually pretty problematic. They just aren't like incredibly grossly problematic. But if you've got capsulitis that's resolved by fibrosis, then you're really not going to open well. And it can be one side or both. And it's just like the frozen shoulder, right? You treat, the subscap, and you treat all the pecs and everything. It's like, wow, I still get that tough fibrous end feel. It'll be the same thing here. Tough fibrous, as you're opening, you're like, oh, it's really fibrous. And then when you shift them from side to side, it will also be a fibrous end feel. If you want, don't dislocate your jaws, but if you want to relax for a second and push your jaw to one side, you feel how you've got like a nice kind of springy feel. You're not going to get that. If they're fibrosed on one side, then you're going to be able to deviate them toward that side not too badly. When you try to deviate them away from the side, nothing. It's going to be like, wow, maybe they go 30 millimeters to the right, and they go like 1 or 2 or 3 to the left. So for someone like that, you can massage them until the cows come home. It's not going to help. Just like a frozen shoulder, the person has to be on board. Okay, so if someone's got a frozen jaw and they want help with it, there's a whole consent thing, because, you can awaken a sleeping dragon there. So if you've got consent for that, maybe they want more functionality, or they don't like the appearance that, it's like I'm talking like I have marbles in my mouth and I can't open my jaw, then, you've got some kind of a process for consent. The way you're going to loosen the jaw, and I don't know if you're going to do it, but the way the jaw is loosened is through joint mobilization. You put some deep moist heat on there, and you do not, I don't like anyways, forcing opening. There is an appliance called the screw, which is a plastic polymer thing, and it's like a gigantic screw. It's like this big, and it tapers down to like nothing, and it goes really wide. And you get the deep moist heat on there, and you screw your jaw open, and you take the slack out of it, and you keep the heat on there 5-10 minutes or so, and you repeat that. So it's heat, long, sustained stretching. So so I did not tell you to do that. Okay, you're on your own if you do that. But that's what can be done. That's an what do you call it? It's an osteokinematic stretch. You're like, I'm gonna want the jaw to open. I'm gonna do it, and you're not really doing it from the frame of reference of the jaw. There's another appliance which is like it's like pliers. They go into your mouth, and when you squeeze them, then it distracts. So it doesn't open your jaw. It pulls your jaw. It pulls your jaw down. Whoops. Sorry, I can't see what I'm doing here. So the distraction is this way. It's like down towards your feet. Sorry, this is terrible. So instead of like forcing the jaw open this way, it's stretching this way. This tends to be, a safer thing. But really what you need to do is you need to do joint mobs that are directed towards the joint. And what you need to do is you get the person lying on their side, and then you mobilize them in all these different directions. I haven't, I know I've got colleagues that do that, like physio colleagues that are very good with it. I'm a little shy. I've done it 2 or 3 times with people that didn't have frozen jaws, but I could feel that there's a capsular restriction there, and I could feel the vector of it. These mobs in particular, I believe they're in Hertling and Kessler, if you want to see them. But, really, you got someone with a frozen jaw that really wants help, I think you're looking at a referral, unless you get trained up. I think John's a chiropractor. John, do you want to say anything about this? Anybody else? Oh, John's here? Yep.
And I have treated it for more jaw. Yes, I am.
Do you do activator, or what's your kind of therapeutic strategy?
I have to do the activity for life, but my preference is just to be very weak. I think oscillating or talking about the idea of laser stimulation, joint itself, that I do. But I want to gently release it. Even breathing a lot better than that.
Okay, John, I'm only picking up about every third word on that. I think you got some expertise there that'd be good to share. So maybe if you could shoot me an email or something, then we'll get this.
Better now?
Yes. Yeah. So what's your approach again?
Yay. Well, I mean, you can use activator or central where you can tap the joint. I like to do manual work, laser and more light therapy, one dog shop now. But I've done manual distraction where you pull down like we talked about the flyer thing. I really don't want the idea of vitals or hard.
Oh yeah. That's the screw's scary, eh? Great. Maybe
You know, just like I can work the shoulders for time, and you have to be careful because if you do it under anesthesia, something can come out that's damaged.
Yeah.
Don't like that. I understand that.
Great. So John, I'm having a hard time hearing you, but I think I'd like to know what you have to share there. So let's take this off like after the webinar, maybe shoot me an email or I'll shoot you one, and we'll figure out the best way for you to share some of this, because it is important to know how other people roll. Okay?
How other people roll. Sorry. Is that better? Can I hear that way?
yeah, it's a little bit better.
All right.
Okay, but I think let's bracket it for now though, because I want to see if there's anything else that people want to discuss for now.
Okay.
Thank you. Okay, anybody else? Oh, I think it looks like some people are still mute here. Okay, somebody have another question? Okay, I see Mara has been muted here. I'm going to unmute her. Okay. Mara,
Thank you.
you were talking earlier. Do you have some more stuff you want to look at, or?
Can you hear me?
Yeah, perfectly. Your microphone gets like a grade A rating.
Okay, perfect. I was wondering if you ever feel the need to, or have the client to laterally deviate the jaw in order to access the lateral pterygoid.
Yeah, a little bit. Not much. Basically, when you're in this top, there's a whole gap here, eh? I'll get you the white background here. Or a simpler background. So when you're in this space here, the inside of the coronoid, you can run out of space there. It's amazing how much variety there is in people's skeletal architecture. We see people who are like tall and thin and wide and endomorph and mesomorph and ectomorph and everything. But I'm telling you, man, like there are racial differences with the shape of people's skulls. And sometimes I'm going in for the the medial pterygoid. I'm like, wait a minute, like I'm practically in up to my wrist. Like when am I going to run into the pterygomandibular raphe? So it's the same thing in here. Like this is the tight place, either for the temporalis tendon. So for the temporalis tendon, if you can't get enough room, I get them to open a little bit and laterally deviate. So if I'm like this and I'm like running out of space, I get them to open slightly, not that much, but all you need is like 2 millimeters. And then same for the lateral pterygoid here. So for the lateral pterygoid, you're coming in here, and really you want to, it's usually no problem getting to this part. This is the lower head of the lateral pterygoid. Getting up in there is tough because you sort of have the, you're going to be running into the coronoid. So I do have them shift a little bit, and then that allows me to get up there. Either I come up, I'm just using the edge of my finger here, or I come up, I go in and I up like this, and then I'm using this edge of my finger. So when I turn like this, then I often have to have them shift the jaw a little bit. That's what's working for me.
Okay.
Yeah. It's
Another quick question.
sorry, just before you, it's nice if you can, share one of these with some buddies or something, just to confirm the landmarking. Like, this course is fabulous online, but if I could just give you like 60 seconds, like with my finger in each person's mouth, then then you'd have a real confirmation, like, oh, right. Because it's common for people to just be off, a couple millimeters, and then you're just kind of reaming some kind of soft tissue. So, Mara, you had another question or a suggestion?
Yes, I was watching one of the videos from the course yesterday,
Mm-hmm.
the one related to the outside of the mouth distraction, bilateral distraction.
Right.
And first of all, I was wondering if the rhythm or the breathing or of the jaw is related to the air breathing, or is it a totally separate rhythm?
I don't feel it in synchrony with the respiratory rhythm. I think it's I don't know that your mandible. That's a whole different thing. Maybe the way to think about it is if you've got craniosacral skills, that's great. You can feel that the mandible has got like this kind of flare thing going on. If you don't, what you can do is you can actually push the mandible medially and let it recoil. So this thing's not moving much. I mean, it is plastic, right? But if this was a dead bone, it wouldn't have much spring to it. But a living bone does. So the old osteopaths used to say, like, dude, if you want to understand, a living bone, you need to look at a living bone. Just like if you want to understand a tree, you don't look at a telephone pole. It's like telephones poles, you don't see them waving in the wind, but you got a willow there with all those branches and everything, and the wind is going, and it's got a whole different quality. So living bone has got this, it's got extensibility, so much so that there's in Moore's Clinically Oriented Anatomy, it comes out of Toronto, it's a book people have used forever. There's a picture where Moore had dipped somebody's fibula, the lateral lower leg bone, in acid for a week or two or whatever, and it pulled out all the salts, and what was left was just the fibrous tissue, and he actually tied the fibula in a knot. So in living bone, there's compliancy and recoil. So what you can do is you can just very gently feel the person's mandible, and you push it medially. See how I'm pushing this one? Push it medially and let it recoil. Push it medially and let it recoil. And there's a lot of different rhythms in the body. And every, the cranial people have got one, the biodynamic people have got another. There's this guy from Germany or Austria recently, and he's got this logarithmic approach. And there are like dozens of different rhythms. So you're not being calibrated relative to me, or someone else. This is your client, it's your practice and everything. So I'd say induce a compression and feel it recoil. And you play with that in a very subtle level. And then you'll feel after, half a minute or so, you'll feel that sometimes it's easier to push it in and sometimes it's harder. So then you're like, oh, okay, there's actually the extensibility of the bone fluctuates. And you respond to that extensibility until you're, quote, dancing with it. And when you're in that kind of therapeutic space, then you're really listening to a rhythmic quality of their osseous tissue, and that gives you a lot more sensitivity. It's not necessary, but that's how, if you want to if you like to foster that level of sensitivity, that's a way to do that.
Thank you.
Thanks, Mara. Anybody else? Come on, this is your chance. It's lonely out here in cyberspace. It's so fun, to really wow, there's people out there.
I have another one.
Okay, Mara.
So related to the bilateral distraction.
Yeah.
When you do the distraction, you said you want to use gentle pressure, but
Yeah.
do you feel you need to take the slack off the skin first and
Ah.
then move down, or just so that the skin doesn't move over the
Yeah.
master and all the other stuff?
Yeah. That's a good question. Once again, you could. What do? I think I do a lot of different things, to be honest. And yeah, so when I do that with myself, I am taking the slack out of the skin to the first motion barrier. And then when that happens, my awareness drops. So it's not that I'm thinking about taking the slack under the skin. I'm just sort of holding the jaw and I'm shifting it down. There's this whole thing, right, around what my predilections are as a therapist. So if I'm really someone who's, if I'm thinking in layers, then I'm going to just do the very first subtle drag. I'm just going to drag the skin. If I'm thinking articular, I have a very similar kind of contact. Watch this. I don't know if you can see any difference. Let's see what happens. So I'm gonna do the skin thing. First, I tune in. Okay. So my jaw's flaring. My jaw's narrowing. It's flaring and narrowing. With this sensitivity, I induce a drag. Okay, so I'm listening to the bone, and then I'm encouraging the bone to descend toward my pelvis. And what that does is it takes the layered approach out of it a little bit, and it really speaks to the bone. So you're going to be really fairly quickly, you're going to be challenging the elements of the capsule of the joint as well as elevator muscle restrictions. It's not the right way. It's just the way that I employ when I'm articularly focused. And I'm using that as my frame of reference. If if there's some kind of scarring or something, that was superficial, then I would be thinking, of the layers. And it should be more like this kind of thing. As opposed to, you can see it, right? I can see it. So I'll do the layers thing in the skin. That's it, like that. When I think of the bone, it's like that. So my skin is not being traction. My intention is dropping in, further into the body. And the last thing I'd say about that, I think it's the last thing, is that as a therapist, I try to attend to the most significant restrictive element. So I think there's probably a very quick and relatively unconscious evaluation of the layeredness of the person and where I wish to direct, my intention as I'm doing this. I have no preference, want the mandible to go down toward the hip thing. What do you think?
Okay.
Okay. Is that helpful?
That was good.
Yeah? Okay. Anyone else? Ashley, you're very quiet. Shelly. Nina, I don't think we've heard from you. Charlene, how are things going for you guys?
I'm good. I have
Pretty good.
That's Nina, Ashley.
trying to spare everyone.
Okay. Okay, so what I would suggest you guys... Oh, hello.
I appreciate the review though.
Good. This is my first... there's a better conferencing software thing, and I thought that I was loading that, and I loaded this one. So it's a little bit more awkward than it would have been, I think. I'm pretty excited about the possibility of having a little bit of interaction. I mean, I put a lot of time and effort to try to create this product that would stand alone, but I think it's there's room for all sorts of excitement. Like if other things that could happen is, like, from the evaluation, I actually could have treated Janice, and done like a full treatment and checked in on it, and we could have seen things. Or with this other software, I can actually, if you've got a webcam, you can have your buddy there, and you can show me, or you can show us, what you're doing or what you're having problems with and stuff. So there's a whole possibility, for some connection, over a distance. So okay. Have all of you guys registered with the Facebook Lounge for TouchU? You can see my screen. I'm going to take you there on my browser, and you can see what a cool place it is. I know some of your names I do recognize from there, but a bunch I don't. And between this is kind of an unusual thing for us to get together the way we are right now. But on Facebook, I've got a closed Facebook group that's just for people who are taking courses at TouchU. And I guess because I'm running the webinar, my browser's not opening very quickly. Oh, there we go. So this is the TouchU Community Lounge, and I believe you've got an invitation to the lounge when you're registered in the TouchU website for this course. And these are some of the fabulous people in the lounge. And what you can do is you can hang out and stuff, but you can also ask questions of teacher type people, like me or Kathy Ryan, who's like our fascial expert and stuff. So here's Sarah Bemis. She's got something that she wants to talk to people about. This person's got TMJ dysfunction. She's also got irritable bowel and this and that. And she wants to discuss the case, and other people are jumping in there. And I've been holding back, but later tonight or tomorrow, I'm going to put my 2 cents worth in there. Oh, look at this. So you can see there's quite a few. There's 3 other comments. Yeah, there's a whole discussion thread of people making fabulous suggestions. Here's Mia. She was having problems with the video connection thing there, so I fixed that for her. So that's, we have contests and stuff. There's a bunch of people that I asked them to come up with like fabulous, in 6 words or less, how would you pitch this the head, neck, and jaw course? And it was Elaine's suggestion around, when TMJ bites, you can help. So, I gave them free access to the course for contributing and stuff. So I'd encourage you to go to the, if you're on Facebook, this is a place where you can go. You just apply to it when you go to the lounge, and within a day or two, our bouncer in the lounge will give you access. Okay, well, I've had a good time. I hope you guys, have enjoyed yourselves and learned things. If you have comments about how to make it better, you can shoot me an email, or even you can, why don't you post in the lounge, this rocked for me, or whatever. And it looks like 1 or 2 people are checking out. What I would say, if you want to do something nice for me, what you could do is, you can tell people on Facebook or social media of some kind about the course and where it is and how fabulous it is. And if things are not fabulous, please let me know, because I want to be responsive. Okay, anybody else? Okay, you guys.
No, thank you very much for your time, though.
Okay, well, thanks for joining with me here. Okay, good night, you guys.